Good afternoon, everyone. I have a few housekeeping comments. We recognize people are still getting their, actually others are. So welcome to the Innovative Discovery series. For CME credit, you must sign in. Don't miss our February 1st TED Talk. Paul Cohn will be coming back to give the presentation from that presentation. Also, please note on February 9th, in the Innovation Discovery Series, we have a special guest, Dr. Velma Scattleberry, transplant surgeon. We'll be speaking on ongoing issues of kidney transplant. Please join us and register. Full schedule is posted on our website, Delaware CTR. Series of discussions. And lastly, registration is still open for the ACCEL Community Research Exchange happening March 12, 2018. Keynote speaker for the event is Dr. Georgia Dunstan, the founding director of the National Center, based out of Howard University. She's an accomplished speaker on health disparities and her topic is going to be discussing how the Genome Project can help address health disparities. Very, very exciting. Today we have a special treat. It is a high honor and personal privilege to Dr. Meghan Lane-Fall. She's a visiting scholar. Means that she is a member of the Value Institute, part of this visiting professorship concept that we've been promoting. It's also near and dear to my heart because she's a fellow anesthesiologist and intensivist. She has a very accomplished. She is on the faculty at the University of Pennsylvania. She's a graduate of the University of California, Berkeley. Double major in molecular biology and studies. Got her medical degree from Yale, where she graduated with honors, part of the Alpha Omega Alpha Honor Society. And she has a master's from the University of Pennsylvania. She's a Robert Wood Johnson scholar, and she's here to talk about her Robert Wood Johnson project that will be done in conjunction with us. Here. He has given multiple lectures, published multiple papers, and I just want to mention a few very interesting. Looking at the current grant is entitled Context-Specific Standardization of Operating Room and Intensive Care Unit Handling. And she's written some very interesting thought pieces for our signature that have high impact. She considers herself a self-taught human factors person, which is something that I learned from her talk that you'll see some little embeds in there. Theology as a profession has human factors hardwired because we learned from aviation. So without further ado, I'd like to welcome Dr. Meghan Lane-Fall.
All of you for coming. Your faces in the audience, faces as well. So I have a little bit of it to present a project that some of you about. Give me a little. Before I start, I want to thank all of the folks at the family. I want to thank all of the leaders, Dr. Schneider, Kim Kelly, Judy Hensley, names, so I'm going to as an advance. I'm going to try to finish up by about 12:45 so that we've got some people on. So I have a few objectives for you. By the end of this session, I'd like you to be able to do it The first is to recognize the relationship between your handoffs, and the second is to have you be able to give an example of how one might standardize an operating room and to describe the role of implementation science in facilitating. I don't have any conflicts to declare. The work that I'm going to talk about is funded by the Robert E. Johnson Foundation through the program, which is physicians. So I think when you're listening to someone that you don't necessarily know, it's kind of helpful to understand. And I have a lot of different identities, but I think different ones. One is as an anesthesiologist, so I take programs. But I'm also an intensivist, or an intensive care unit who have had surgery or have issues. I'm also a health services researcher about how we deliver health and whether we're able to achieve the outcomes that we set out to achieve. So I really come to this research from. My lab is composed of undergraduates, medical residents, fellows, the researchers who are interested in. The goal of my lab is to advance patient acute care. So if you think about the Institute of Medicine, they advanced 16. My lab is interested in advancing. I'm going to talk a little bit about handoffs and why they're important. When I say handoffs, and how many clinicians? So we're a mix. Good. So when I talk about a handoff, I'm talking about a transfer of patient care, and they're important because by ourselves all the time, we work with other clinicians. Because we have different specialties, and because as much as maybe some groups would want to be in the hospital, and so we have to work together to take care of ourselves, which means that we need to ourselves and share information about that process of transferring care. They've been in the literature increasingly over the last few years. Most recently, 2014, there was a very high-profile showed adverse events with standardization of perioperative. And actually, just 2 weeks ago, there was a publication with adverse events when there were handoffs of anesthesiologists. There are a lot of other studies, but those are probably the most. But clearly, we're being pushed. I'm going to give you a little bit of a whirlwind background on handoffs and hope that you if there information or more questions, and but the clinicians have been interested in safety and healthcare as long as we've been in health. But in the last 20 to 30 years, we're going to evaluate quality of care that we render and whether we're able to. And I would argue that one of the seminal papers in this recent era is when Mission Week published. Mission Week is a surgeon based in Boston, and really he sort of pulled the cover back and said, no. If you look at the leading causes of death in the United States, well, healthcare related is not up there. There are some estimates that 140,000 prevent. That is a smaller proportion of 4 to 8. But if you put healthcare related deaths, just with all the rest of the deaths, the magnitude. So clearly, there's room for. healthcare errors cause preventable. Now, if you step down, I'm going to sort of step you through my logic to get to Handoffs. Healthcare errors are mostly, there are lots of reasons that we might make mistakes under a patient, but the Joint Commission estimates that 70% something to do with the way that we communicate with each other as clinicians is predisposing. Handoffs are a particular type of, and they're estimated that about half of those communication-related defects. Hi, everybody who's online. So handoffs are linked to about half of those communication-related errors, and they're particularly prone to defects, in part because we don't necessarily communicate efficiently or effectively when we're handing off patients, and I'll step you through why that is, but we don't necessarily have a common framework for understanding how to communicate when we hand off to patients. And in the absence of that framework, it's very easy to make mistakes. If you add in human factors related issues with fatigue or information overload, it makes it very easy to introduce error into the handoff process. And we know that standardizing handoffs improves quality. And I can take you through all of the evidence. I've just cited here the New England Journal paper that I talked about earlier, but there are a mountain of studies that show that if you standardize handoffs, you improve process outcomes. A smaller number of those studies show that you improve patient outcomes, but that evidence is evolving, and there is increasing evidence that when you standardize handoffs, you actually improve patient outcomes as well. And so that's here. So when you improve handoff quality, you actually get better patient outcomes. So this is really a whirlwind stepping you through the logic of why we're even talking about handoffs in the first place. Really tracks back to healthcare errors and preventable harm. So in surgical practice, we have a lot of different kinds of handoffs. And this is also one of the difficulties in thinking about this work, is that we're not always comparing apples to apples when we talk about handoffs. And so I want to point out that as we transition care between transition care of patients between providers, there are a couple of ways we can do that. The most important are transition of care and shift-to-shift handoff. And I should note that this taxonomy is not agreed upon in the literature. This is a paper that I published with collaborators at University of Alabama at Birmingham. This is the terminology that we've used and that other people have used, but there is still a little bit of question in the literature about what exactly to call it. So a transition of care is a handoff in which you have a patient moving from site to site of care. Imagine a patient going from the emergency room to the ward, going from the operating room to the intensive care unit, which I'll talk about at length, or going from hospital to home. You have a patient moving from site to site of care. You have teams on either side of that transition that have different goals. So if you think about an ED, emergency room or emergency department to ward transfer, the emergency department team wants to stabilize a patient. They've triaged the major issues. They want to get that patient out of the ED so they can see more patients. So it's about throughput, it's about efficiency, it's about stabilization, it's about making sure that that's okay enough to get to the next step of care. It may not be about definitive diagnosis. It may not be about necessarily big picture issues. Clearly they're interested in that, but in the short term, they have different concerns. When you think about the ward team, on the other hand, what is the definitive diagnosis? That's what they want to know. How do I get this patient well? How do I get them home? What are some of the bigger picture issues that may be factoring into the presentation? They have other patients to take care of too, but their time course is different. And if you just imagine what those two teams are trying to balance, clearly the conversation that they have could be compromised if they don't understand the needs of each other's needs. And so there are special risks that are introduced when you have a transition of care, when you have a patient going from site to site. That's very different than a shift-to-shift handoff, where you can think about clinicians who are interchangeable actors. So an example of this might be in the operating room. To go back to that JAMA paper, you have one anesthesiologist who needs to go home. They're going to hand off to another anesthesiologist. They have the same type of training, presumably the same skill set. The things that they're going to do are exactly the same. So it's really that handoff of a baton. I'm going to continue doing what you're doing. That exchange is very different and potentially needs to look different and be structured differently than the first type that I talked about. So when I talk about operating room to ICU handoffs, I'm really talking about that first type, which is care. But keep in mind, if you know the literature at all, a lot of that literature is about shift-to-shift handoffs. And so some of the concepts may translate, but they won't all translate because it's really fundamentally a different kind of activity.
The third kind of handoff that I'm not going to talk a lot about is duty relief, which is the idea that you have interchangeable actors, but it's just for a short period of time that handoff is occurring. And so it may be that I need to go to the restroom, I need to have lunch, and I'm going to come right back. And so the kinds of things that the person who's relieving me need to know, they may not need to know that much. They need to know enough to keep the patient safe, but maybe they don't need the big picture. And we know much less about that kind. So there are lots of reasons that handoffs fail. One, human factors. Dr. Jackson alluded to human factors, and I am not going to pretend that I'm a human factors expert, but I am a human factors aficionado. I appreciate it. So human factors is the discipline that's concerned with how people do work, how people use tools and strategies and policies to accomplish tasks. One of the human factors related issues that can factor into handoffs failing is that people get tired. So we have a certain amount of energy that we can marshal, and maybe we can drink some more caffeine, but there's a point at which we're tired enough that we're not clearly. And if we are tired, that can factor into our ability to communicate effectively. Information overload is an issue. And so there are some thoughts that we can keep about 7 things in our short-term memory. And if you give someone more than that, they won't be able to process it. And so you can imagine for a complicated patient who has diabetes and end-stage renal disease and heart disease, who had a 3-part surgery, that's already 6 things. If you're trying to hand off that patient's care, it may be very difficult to do that effectively if you're relying on someone. The third factor is a false sense of security. And as we get used to taking care of patients, in the OR, we could say, oh, this is a straightforward lap chole, no big deal, 2 IVs, you're fine. We may sort of undercut patient safety because we think that we know exactly what's going on, and we don't necessarily give the same degree of vigilance to every single case because we're comfortable. There are systemic factors that can influence whether handoffs go well or handoffs go poorly. One is a lack of standardization. So if we don't have a common framework to think about how these processes should happen, if there's something missing from the handoff, it's going to be difficult for us to figure that out because we don't have a common framework or a thought about how it should happen. And so not having a framework or a standard introduces the possibility of error. Lack of reinforcement is also an issue. And so for medical students, for instance, if we tell them handoffs are important, safety is important, they go on the wards and they see their attending say, handoffs don't matter, like, whatever, you're fine. What they're being told, the implicit message that they're being told is that this really isn't important. And so they won't pay attention to it because it's not reinforced. A third issue are communication failures. One type is content omission, where we forget to tell someone something. A second type is incorrect information, where we tell someone something that's not true. And a third, which is more interesting to me, is differences in clinical knowledge. And I'll go back here to the operating room as an example. We have residents who are new to being an anesthesiologist and attendings. We have CRNAs and SRNAs and all of this. But imagine a resident who has been a doctor for 4 years, 3 years, maybe 2, and an attending that's been a doctor for 20 years. There are situations where they might hand off to each other where the technical skills, the physical things that they're doing are exactly the same. But because they have differences in knowledge and experience, the assumptions that they make, the suppositions that they make are going to be different. And if you have one handing off to the other without explicitly saying, this is what I believe to be true, this is what I think is going to happen, you introduce the risk of harm, even though they're doing the same job. And then there are clinical factors like complex patients. This reminds me of a patient I took care of in fellowship. This is actually her CT scan. It's a woman who was pregnant who had a placenta percreta. So the placenta was growing into her uterus, into her bladder, and she needed a C-section. But she also had massive pulmonary emboli, which you can see up there, and right heart failure. And there was just a lot going on. And you can imagine the more complicated a patient you have, the more there's an opportunity for error during the handoff. So lots of reasons that handoffs can go awry. But handoffs are not all bad. There are some good things that can happen with handoffs. If you think of them as a teaming activity, if you think of them as something that we do together to take care of a patient, we can do something called distributed cognition, where we're thinking about the patient together. We're constructing a shared mental model of the patient, and we can actually have insights about patient care that we wouldn't have had by ourselves. And so a handoff is an opportunity to think about the patient in a new and creative way and maybe have insights and develop care plans that are more appropriate because we've worked together to think about the patient. They also provide an opportunity for social interaction, and certainly in the OR behind the ether screen, sometimes we get a little bit lonely, and so the opportunity to talk with people, to bounce things off people can be useful as well. So I'm going to move on to talk specifically about operating room to ICU handoffs. There are lots of different kinds. There are shift-to-shift handoffs, all the transitions I told you about, but we're really going to hone in on this particular type, which is what we're going to focus at Christiana. So when I talk about an OR to ICU handoff, I realize that we don't have a lot of, or that we have a lot of non-clinicians in the room. And so this is what I'm talking about. This is an interaction where you have a patient who's had surgery and they are critically ill enough or they're at risk of deterioration, and so they need to go from the operating room to the intensive care unit. Now, Christiana, sometimes those patients will stop in the PACU at first to be stabilized, to be recovered, and then they'll go to the ICU. But ultimately, this is a person who is high risk enough that they need critical care services. What we're talking about is a teaming activity, a situation in which you have members from the operating room team, potentially members from the PACU team, that are taking the patient to the intensive care unit, and they're interfacing with the ICU team that is a nurse and an ordering provider, usually a physician or advanced practice. And what they need to do is have a conversation about who this patient is, what they've been through, and what their needs are in the postoperative period. And what I've conceptualized here is a cohesive conversation in which one person's talking and then another person's talking. It doesn't always look like this, but this is the basic sort of idea. This process can be high risk for a lot of reasons, not the least of which is that you have often an incapacitated patient who cannot contribute to their own care. And so if you think about if you're a patient in the emergency department and one physician goes out and another one comes in and they say something that's wrong, you'd be like, no, that's not right. I don't take that med. I don't do that thing. The patient can't do that here. So they're entirely dependent on us to communicate on their behalf. So there are some problems that can happen with OR to ICU handoffs. The first is that you've got a patient moving from site to site, and so there are some logistic issues with actually moving them, and they can potentially deteriorate as they're being moved because it's hard to move a bed and pay attention to someone. We're moving technology, so we're moving invasive monitors. We've got multiple teams that are talking to each other. They're from different disciplines. They have different priorities, similar to what I mentioned before. So the OR team is trying to do this transition and then they need to get back to the operating room. The ICU team does this transition and they need to get back to the rest of their patients. And then all of this happens under time pressure. The consequences of a poorly executed handoff are that you may have physical injuries to the patient or the staff. You may see physiologic deterioration of the patient as the provider's attention is really on the logistics of the transfer. You may see medication errors and errors in continuity that happen when the care plan from the operating room is not continued, perhaps as a consequence of poor communication. There may be information that's missed about dosing of antibiotics or what kinds of drains or tubes or lines the patient has, and the teams may just not work together well because they don't have a shared understanding of what they're supposed to be doing. So you may ask, are checklists the answer? We do lots of checklists in medicine. I'm sure you guys love checklists. Everyone loves checklists. There are some notable successes with checklists in medicine. So the central line bundle that was implemented by Peter Pronavos group in the Keystone Project in Michigan. Similarly, Atul Gawande's work with the WHO surgery, the surgery safety checklist. Safe Surgery Saves Lives was the name of the project. So both of these projects demonstrated that introduction of a checklist improved patient outcomes. Big deal. However, both of these interventions have been implemented in other settings and there was no difference shown when you implemented a checklist. So the central line bundle, there was a project called Matching Michigan that was done in the UK. They were not able to demonstrate an improvement in patient outcomes. And actually there was a decrement in patient outcomes with implementation of a checklist. There are a lot of qualitative studies that sort of dig into why that might have been. Similarly, there was implementation of a pre-surgical checklist in Canada, in a multi-center study in Canada. This was published in the New England Journal as well, and they showed no improvement in patient outcomes with implementation of the Safe Surgery Saves Lives checklist. So checklists may help, but they're not the answer. And if checklists aren't the answer, then what might we do? So I'm going to argue and hopefully support that standardizing OR to ICU handoffs works. And when I say standardization, I don't mean a checklist, and I'll tell you what I mean. But what happens when you standardize OR to ICU handoffs is that you see an improvement in information exchange. You see an improvement in provider satisfaction because they have a better sense of what they're supposed to be doing and they feel like it's being done. You see usually unchanged handoff duration or even a shorter handoff duration, and so people are able to do things more efficiently with standardization. You see decrease in medical errors in some of the studies, but not all. And you see improvement in achievement of clinical goals. And one example would be time to extubation. So when you move a patient from the operating room to the ICU, often they have a breathing tube in place. This is especially true after cardiac surgery. And one of the goals in the ICU is to get that breathing tube out as soon as you can. And so you may actually be able to do that sooner if you go through a standard process. What I'm showing you here is a table or a figure from one of these studies that's cited along the bottom. This is a representation of what happens when you standardize operating room handoff. So what you're looking at along the x-axis is a percentage of information. Basically what they did was they stationed people in a room and they had them listen to what was being said, and they had a list of things that were supposed to be discussed. And if you didn't say it, that counts as an information omission. So where you don't want to be is on the right end of that graph. So my pointer here so that the other people, the blue jeans people, can see it. So where you don't want to be is over here. You don't want to omit information. What you see along the y-axis here, it's not really a y-axis, but what you see here with the stacked bar charts are all of the different things that might have been discussed in a handoff. And what happens when you standardize the handoffs is that you see a regression toward this end of the figure, which is where you want to be. And so for each of these types of information, you'll see the pre-intervention error rate, which is the dark bar, the post-intervention error rate, which is the light bar. And you'll see for each of these types of information, you see regression toward where we want to be, the exception of weight, which wasn't statistically significant. So what this is demonstrating is that across a number of information domains, you'll see improvement in transmission of information with standardization of handoffs. And across the 20 plus studies that have been published in this setting, you'll see the same type of thing, that information omissions, which is a process outcome, decreases with standardization of handoffs. So when I say standardization, what I'm talking about is really a choreography of handoffs. There are two parts to this choreography. One is the handoff process. So this is the big gray box. What you'll see initially is that you've got some pre-handoff preparation in which in the operating room there's some communication between the OR and the ICU, or the OR and the post-OR setting. There's a call that says this patient's sick or they're not sick. They need a ventilator. These are the things you're going to need when we get there. After the surgery is complete, you'll have the patient being transported to the ICU. The patient's then stabilized and put back on the mechanical ventilator if they need to be. Make sure that the patient's blood pressure is okay, that their heart rate is okay. You move all of their equipment over, their transport monitors, and only at that point do you exchange information. And that information exchange is guided by a handoff tool or a template, which you can see over here in this inset box. And the elements on that handoff tool in the published literature tend to include the things that are here. After information exchange, there's a discussion and an opportunity for questions. So when I say standardization of OR to ICU handoffs, this is what I'm conceiving, which is this choreography of this whole process. You're essentially telling the team, this is what you should discuss, this is where you should be, this is how it should go, so that everyone has a shared understanding of how the process should go forward. So if that's the evidence, and that's understandably a whirlwind overview of the evidence, how do you actually get people to do it? So this is where implementation science comes in. So implementation, I'm just going to read this because I think it's important. Implementation includes the translational efforts that take healthcare interventions beyond the closed systems of evaluation studies, so the randomized controlled trials, into the open systems of real-world context. The outcome of these processes depends on interactions and negotiations between participants and their context, or their participants and context. In a typical randomized controlled trial, we try to eliminate variability about everything except the intervention. We want the patient population to be clean. We want the setting to not matter. We want to just look at the effect of our one little intervention. In implementation science, we embrace variability. We appreciate context, and we want to know how context impacts the implementation or the translation of evidence into practice. For an intervention like standardizing OR to ICU handoffs, I would argue that it's impossible to do the gold standard RCT because there is no clean setting. The cleanest setting would be a simulation lab, which has questionable translation into real-world practice. And so we're left with this, how do we actually evaluate this evidence and get this evidence into practice in the messy real world? The reason that implementation science exists is that there is a time lag between different phases of research. And so when we think about research, the translation of research into practice, there's something called clinical efficacy research, where efficacy is, does something work in an idealized setting? So that's the randomized controlled trial or the simulation lab, the cleanest possible setting. Once we've demonstrated or we think that something is efficacious, we'll then translate it into effectiveness work, which is real world evaluation work. And at that point, then we try to get it into practice. And there's supposedly a 17-year lag between evidence and practice. So we determine that something is efficacious. We say, yes, we should be giving aspirin to everyone who has an MI. And it takes 17 years on average for that to actually reach patients. The point of implementation science is to try to bridge that evidence to practice gap, to try to narrow that gap, to get evidence into practice faster and more effectively. Implementation outcomes are different than effectiveness outcomes, and the types of outcomes that we look at in implementation are things like acceptability and appropriateness, so understanding whether an intervention fits well in a given environment. Is it acceptable to the people that are going to be doing it, and is it appropriate? Does it fit in that environment? Feasibility is another implementation outcome where we figure out, will an intervention actually work in any given environment? Are the costs low enough or reasonable enough? Are the providers skilled enough to actually execute the intervention? And then fidelity. So once you have implemented an intervention, are people actually doing that intervention? So in contradistinction to effectiveness outcomes, which might be mortality or length of stay or patient symptoms or patient satisfaction, implementation outcomes look very different. There is a relationship between implementation outcomes and effectiveness outcomes. And this is essentially a takeoff on Enola Proctor's model, which is a takeoff on Donna Beatty and structure process outcomes model. But essentially the idea is that implementation outcomes are related to process outcomes, which are related to patient outcomes. And so the way that I put this together for OR to ICU handoffs is that if you have an intervention that is acceptable and feasible, so people think that it's okay and you have the resources to actually do it, then they will adhere to that intervention. You'll see fidelity. If you have fidelity to an intervention, you'll then see improvements in your process outcomes, which here I've conceptualized as teamwork and communication. If teamwork is appropriate or is acceptable, is good, I'll say, and communication is also good, you'll see appropriate care, continuous care, and improved provider outcomes, which then translate into patient outcomes. So this is the top level overview, but then you can get much more granular and you can look at, well, what are the particular things that I would measure to look at each of these relationships? And so I won't go into detail here, but this is just to give you the sense that this gets complicated very quickly. But the nice thing about laying out the relationships this way is that you can then see what a study would look like, and you can characterize acceptability, fidelity, teamwork, all of these other measures, and you can test whether the relationships that you think are at play are actually there. So that's what we did at Penn, at the University of Pennsylvania, and I'll tell you a little bit about the work that we did and how we hope to translate some of that work here. So the study I'll tell you about is called HATRIC, which stands for Handoffs and Transitions in Critical Care. This is a screenshot from our website, which is still live, so if you'd like to go there and learn more, you're welcome to. You have to remember how to spell HATRIC. That's the only trick to this. These are two of our nurses in one of our surgical intensive care units. HATRIC is structured as a hybrid effectiveness implementation trial, and that's going to be the structure of the trial that we have here that I'll talk about. The idea behind hybrid effectiveness implementation trials is that you're looking at effectiveness and implementation at the same time. So those effectiveness outcomes I told you about, which are both process and patient outcomes, things like information transfer, but also patient outcomes, mortality, length of stay, adverse events, those are the effectiveness outcomes. And you look at them at the same time as you're looking at implementation outcomes, things like acceptability, appropriateness, feasibility, and fidelity. We're going to be structured, and we were structured at Penn, as a type 2 hybrid effectiveness implementation trial, which sort of equally weights them and looks at the implementation outcomes in similar depth to the effectiveness outcomes. So the outcomes we looked at reflected the fact that we were a hybrid effectiveness implementation trial. There were implementation outcomes and there were intervention outcomes, but it's also a mixed method study in that there were qualitative outcomes and quantitative outcomes. The primary outcome was information omissions. And the reason that was the primary outcome is that the preponderance of the studies that have been published in this space. So we wanted to be able to situate ourselves in that literature. At Christiana, what we want to do is power the study to look at changes in patient outcomes, because really what we want to do is improve patient health. And it's great to show that you've improved process outcomes, but really the goal is to improve outcomes for our patients. And so that's one of the reasons that we're here, but I'll tell you more about that. The protocol that we developed, the Handoff standardization protocol we developed, looks like this. And in the interest of time, I won't go through all the steps, but basically this is the choreography. It's the same as the clock diagram I showed you before. It's just a little bit prettier because we had a graphic designer. But basically there's communication before the patient gets to the ICU, the patient arrives and is stabilized. There is confirmation from the team that's going to do the handoff that they're ready. And then sort of like kindergarten, one by one, they talk about the patient, develop a shared understanding, create an opportunity for discussion and questions, and the handoff is complete. And what we found is that information exchange improved with use of a handoff protocol, which is not entirely surprising. But we also found improvements in professionalism and teamwork. And what I'm showing you here is something called a heat map, where you're looking at the leftmost column here is information omissions, where red is bad and green is good. I apologize for colorblind folks, but hopefully there are enough gradations in the shading that you'll be able to see. Good is at the top. So you'll see that there were a significant number of handoffs before we started that were in the red, where there was a lot of information omitted, and you see many fewer over here after implementation. But we also look at changes in teamwork and professionalism, and you'll see that there's not a one-to-one relationship. You can have a handoff that has very little information in it, but also has good teamwork and professionalism. And conversely, you can have a handoff with bad teamwork and professionalism and good information exchange. But I would posit that you really need all three to have a good quality handoff. But you can see that all of them improved with standardization. We also looked at implementation outcomes, and I'm just going to tell you about acceptability. We looked at acceptability qualitatively and quantitatively. We used surveys to quantitatively assess acceptability, and we found that the majority of our providers found that this process was acceptable. Most of them used the new process, and most of them also said that the process made patient care better or much better. And importantly, no one said that the process made patient care worse. When we looked at acceptability qualitatively, we looked at interviews and focus groups, but we also looked at our event reporting system. And so I included something here from our event reporting system. So this is our confidential, there was an adverse event and we put in a report, someone can follow up on it. What I want to demonstrate here is that people were using the term hat trick to describe what was happening with care. There actually wasn't an issue with the handoff in this case, but this demonstrated to us that this became so much a part of the fabric of everyday work that they were describing their work using this term. And we actually found that people were using the term hat trick both as a noun and a verb, and people would walk in and say, are we ready to hat trick now? Or we're hat tricking. And so there was something about the name that really took people, that struck them, and they started incorporating it into the way that they talked about clinical care. So moving to Christiana, the goal here is to translate some of the successes that we had at Penn to another setting, specifically this setting, and I'll tell you why. So you all are a behemoth in Delaware. So Christiana provides 90% of the adult non-VA care in Northern Delaware. Your population is much more representative of the country as a whole than is a quaternary referral center where we're used to seeing zebras and not horses. So the question of whether the evidence that we generate in that setting actually would be relevant to care in the rest of the country is a really important question. And so that's one of the reasons that we're here. The second reason is that Christiana is very clearly committed to advancing safety and quality research. The Value Institute is a very clear demonstration of the institutional commitment, but even just walking around the hallways, even on the phones, it says we serve together. In every room, there are posters that talk about the commitment to quality. And so Christiana represents a very important setting to do this important translational work of figuring out, can we translate evidence into real world practice? So that's why we're here. What we've done, we've been around here for a couple of years now. We have an IRB that's been approved, which is good. We've done lots of interviews with hospital leadership and stakeholders, some of whom are in the room. We've done some preliminary observations in the operating room and the ICU and the PACU. Importantly, what we figured out is that the patient flow that is characterized in the literature from going from operating room to ICU actually happens differently here at Christiana. So there are patients that go directly from the operating room to the ICU. There are many more patients that go from the operating room to the post-anesthesia care unit to the ICU. And so that patient flow presents a challenge to direct application of the evidence to this setting. So we have to figure out, how do we account for the fact that patient flow is different here. We've been building relationships with local researchers and rebooted our project team, which I can tell you more about if you have questions, but we have a new and project team. So the goals here of the research are to develop a handoff assessment method that's scalable. So what we've done in our prior work is have a very long and involved tool that we give our research assistants to sit in a room and they check off about 20 or 30 different things about a handoff. But that's not really scalable. And so part of what I want to do is figure out how do we assess the quality of handoffs in a reproducible, scalable, flexible way. That's one goal. Another goal is to evaluate OR to ICU handoffs in different settings. So we've conceptualized this as starting at Christiana Hospital in the Wilmington Hospital. We're interested in looking at some of the other ICUs here, and we think that this process may look slightly different in those different ICUs, so we'd like to understand that. We want to figure out how to make these handoffs more reliable, which my language is a little bit different here. So if you heard me give a talk about this project before, we were talking about understanding how the process worked and seeing if there were opportunities for. And I think one thing I've learned in all of my time here is that there are opportunities for improvement, that people are really interested in trying to make this process more reliable. And so I feel comfortable saying that there are opportunities, and we're gonna figure out how to do that. Then we also want to define the factors that are relevant to handoff implementation. Our outcomes of interest are related to the different phases of the project here. And so what we're getting ready to start this calendar year is a needs assessment or the current state, a really deep dive quantitative and qualitative evaluation of exactly how this process happens. We're going to be pulling data from the EMR. We're going to be surveying providers, doing interviews or focus groups depending on which one's more feasible, and then doing observations of handoffs. We'll then design a process in very close work with stakeholders. So this isn't a bunch of eggheads saying this is how it should be done. This is eggheads plus clinicians plus leaders working together to say, what's the evidence? How can we make this fit? How can we make this fit in a way that complements workflow, that doesn't represent just another thing for people to do, but that can make the work smarter, more efficient, maybe even more fun? How do we do that together? Then implementation and evaluation. So the quantitative outcomes I usually get questions about, so we'll do a little bit of a deeper dive here. We're studying this we're powering the study on a composite patient outcome. We're interested in patient outcomes, but death is pretty rare. I have an extra parenthesis there. That's good. We want death to be rare, but from a statistical standpoint, it's difficult to detect a change in outcomes when you have a rare event. So what we're doing is creating a composite outcome, which will increase our power to detect an effect. So the composite outcomes that we're looking at are those events that happen within 24 hours of ICU transfer. And so we are interested in death, but also unexpected return to the OR, intubation or re-intubation for those who are extubated in the ICU, and then major organ failure. And we'll be working with our analysts and our statisticians to really parameterize these variables very clearly to see what we can pull out of the EMR. So that's it. I'll conclude by reiterating handoffs are associated with preventable patient harm, that the preponderance of the evidence supports that OR to ICU handoffs improve with standardization and choreography, and give you the caveat that implementing handoff standardization or really anything in healthcare is not necessarily easy. And so we're putting a lot of time and attention into the implementation strategy in addition to the intervention itself. So I'll acknowledge again all the folks that have collaborated with us and been generous with their time, my lab and collaborators at Penn, and then the funders here. So that's it.
Thank you for that excellent presentation. One question I have is I was actually impressed with talked about the term atrophy by the system, because what I saw that was
right.
And so clearly spaces beyond the operating perioperative environment. Do you think that starting a project like this in the perioperative space, a culture could seep out positive ways to primary care other spaces?
So I'll just repeat for the folks that are remote. Dr. Jackson was asking about, or saying that he was impressed with the use of the term sort of in the terminology that people were using, and that really spoke to diffusion and what's the opportunity for this to potentially diffuse across the hospital and even out into the community. I think that branding is important, and I think I underemphasized or appreciated how much branding is important. I think our marketing colleagues would tell us that, of course, it is. But having a name to call this process is really important and sort of helped with the stickiness of this intervention. I think that the stickiness can help with diffusion, but only to a certain point. And if any of you are familiar with implementation science, we used to call it dissemination in implementation science. The thought was that you could study the process of diffusion or dissemination, but really the field has moved more toward just calling it self-implementation, because it's clear that we have to actively do things to get interventions out into practice. And so I think having a sticky intervention that is appealing in some ways is sort of necessary but not sufficient. And I think that having those qualities can create the conditions for dissemination and diffusion. But I think that part of what we need to do is be really strategic about how do we actually get other people to take up the intervention? How do we make them pull it as opposed to just sort of having it seep around? And I think we may see more success in the uptake of these interventions when we're more strategic about how we get people to do them. So I think it's important, but I don't think it's enough to just diffuse. Yes.
Wonderful talk. Thank you very much.
Thank you.
How are you going to compare your outcomes? So obviously, to increase outcomes, will we do type of a pre-post, or will you implement the handoffs to any surgery here, or how are you going?
So that's a very good question. And the question is essentially, how are we going to assess the differences? Is this going to be a pre-post study? Or are we going to limit the services in which we implement? And I would say initially this is conceived as a pre-post study because of the difficulties in finding an adequate control group. And I think that's one of the things that actually we're going to have to work through with our team is, do we think about doing a stepped wedge sort of approach where we roll out to one unit and then another and look at differences over time and use statistical procedures to essentially control for other factors that may influence. But it's not going to be possible to do a true randomized approach. And even within services, it's difficult because there will be contamination of what the providers do in any given unit. So it's really probably the ICU that's the unit of interest, and it'll be hard to make it more granular than that. Because even if you tell one surgical service, do this process, and you don't tell the other surgical service, you may have a receiving ICU nurse who says, oh, well, I know that process, I'm going to use it because it's better. Or I won't use it for any of my patients, it might go the other way. So I think that we'll definitely do a pre-post comparison, but we're actively looking at ways to try to deal with confounding and to try to be confident that whatever changes we see are actually attributable to the intervention and not to other effects. Yes.
Yeah, great talk. Thank you. A comment and a question, back to the diffusion aspect, in organizations like here, it's going to take some effort to coordinate it because nursing has their handoff tool, there are other handoff developed or trying to be implemented. So it would behoove us to kind of coordinate what that looks like.
Yes.
Otherwise, they'll butt up against one another and a detracted use. Additionally, as you start getting outside of the OR perioperative space and the ICUs in general, where error is sometimes harder to detect and outcomes take a longer time to evolve, can you talk to some of the required nimbleness about measuring outcomes that
Sure.
you may anticipate as you try to go outside the perioperative ICU space?
Great. So the comment was talking about the fact that there are other concurrent handoff efforts happening, and that as we think about diffusing or implementing a process, that we need to work in coordination with those groups, which I completely agree with. And I think that sometimes we do ourselves a disservice in healthcare when we don't necessarily acknowledge the other efforts that are happening in our space. And so that's why for the design phase, it will be a group effort. It has to be a group effort. We have to figure out what elements of what's already happening can we take, and how do we package this so that it's clear to clinicians that this is part of a cohesive effort, and that this may just be another sort of branch of that effort, but not that this is yet another thing to remember and do. So I absolutely agree. The other question had to do with, as we move beyond the perioperative space, the sort of acute procedure-based space where maybe errors are potentially more common or maybe easier to detect, how do we deal with the issue in measuring outcomes as we move beyond into these other spaces, which I think ultimately we'd want to do. So you're right. Thankfully, those adverse outcomes are rarer as we move further out. I think that going back to my conceptual model, if we believe that there is a true association between the process outcomes and the patient outcomes, and actually more strongly, if we think that the process outcomes are in the causal pathway toward the patient outcomes, then it may be that we decide that we're comfortable measuring those process outcomes as a proxy for the patient outcomes. But I think it's important to do that initial work of showing that they are actually and that the process outcomes are the mechanism which the patient outcome. But if we're able to demonstrate that, then I think you can step back and you can say, okay, our outcome is going to be, do they do the handoff? And that may be sufficient.
I just want to clarify. I would posit the errors are actually more frequent outside of the perioperative.
They may be more frequent outside of, yeah.
If someone doesn't get the right antihypertension, but poorly controlled hypertension, error may not be detectable.
That's a good point. That,
So,
yeah,
just
that
the
errors
way
may
we
be
look
more
at it.
common. I think you're right that the time scale is different, and so the errors may manifest differently. But if you look at the complexity of caring for a whole patient and all of the things that are going on with them, I think you're probably right. When they're in the OR, it's, we're laser focused on this particular thing, and I don't necessarily worry about their gout. But when you think about the whole person.
Plus, when it's an error, it's very evident on your monitor.
Exactly. Yeah. We've got a lot of monitoring to figure it out. So, yes.
Again, great talk.
Thank you.
My wheels are spinning because I just listened to a podcast. I believe they were talking about, I think it was Hidden Brain. They were talking. Did you hear this one? It was just on last week.
I like Hidden Brain, so yes.
The theme was like check yourself, and so one of the aspects of this episode was talking about it from in the healthcare setting. So they interviewed Dr. Gawande and Dr. talking about their work with checklists. And one of the things they commented on was what happened in Canada, kind of to try to replicate the work they had done, was they implemented it as a policy and basically required these checklists to be mandatory, but didn't. And they were kind of selling their own work per se, but in Canada they didn't take time to develop the buy-in and maybe the cultural kind of acceptance of that process. So I think it's great that you're looking at acceptability and measuring that. What are some of your thoughts about how to, if acceptability is low, about how to increase it and develop buy-in?
So that's a great question. And the question was sort of thinking you were triggered by a podcast that was talking about some of the work with checklists, and Atul Gawande and Peter Pronovost were talking about their work and how there's been issues with replicating their work, specifically with the Safe Surgery Saves Lives checklist, because it was implemented more as a policy without something else behind it, without building buy-in and engagement. So how might we do that or go beyond that? They're absolutely right. So one of the downfalls of that work, one of the reasons that checklists don't work is that it's not just a checklist, that you can't just sort of plant something on someone's clipboard and say, we're done. You have to think about not only how do you get them to embrace it, to use it effectively, but does it even fit in their workflow? And I think a lot of times we'll come up with interventions, we're sort of sitting in our chairs, not you, but some people sit in their chairs and like, this is a good idea, let's do that, without really looking at the work of the people that are doing it. So I think building buy-in and getting engagement is crucial, but also coming up with implementation strategies along with the people that may implement is really important. And this reminds me of what's called community-based participatory research, which I think a lot of our more primary care-oriented people may be familiar with. I think of this as community-based participatory research, but based in a hospital. The community is the people that are doing the work. The community is the nurses and the doctors and all the other people that are working to take care of the patient. They need to be part of this. So you need to build engagement with them and have them agree with you that this is an issue, and then work with them to come up with solutions. And where the researchers come in is, let's come up with the rigorous ways to assess what's happening, to come up with an intervention, to be clear that we're measuring what we think we're measuring, and to be confident that any effect that we see is actually attributable to the intervention. But this has to be done together. And so sort of a long-winded response, but I think this has to be a group effort And so I really do think of this as a collaborative effort, not just with me and you, but also with all of the clinicians. Hopefully we can all be in it together and come up with something that really fits.
Thank
Thank you.
Dr. Meghan Lane-Fall for wonderful